Good afternoon. My name's Steve Durham, and I'm a respiratory physician and allergist from the Royal Brompton Hospital, and I run a research group at Imperial College London. I'd like to thank the organisers for the opportunity to speak to the Emirates Thoracic Society. This is a great honour. And my title is referred to as Allergen Immunotherapy, Fact or Fiction. Here's my disclosures, some organisational interests, research grants, consultancies, and a few lecture fees. Now, maybe not all of you are familiar with allergen immunotherapy, so I'll give a brief introduction. Allergen immunotherapy involves the repeated administration of allergen extracts or products to IgE sensitized individuals in order to induce a state of clinical and immunological tolerance on allergen re-exposure. And for over 100 years, we've had the subcutaneous approach. And over the past 20 years, the sublingual immunotherapy has become very important as an alternative to the subcutaneous route. And largely, the sublingual route involves the administration of sublingual tablets, although the sublingual route can also involve liquid drops. Now, there was an excellent position paper for allergen immunotherapy published over 20 years ago, which just highlights the key points, that this treatment is effective in IgE-mediated disease, particularly where there's a limited spectrum of allergies. It's effective for allergic rhinoconjunctivitis, allergic asthma, and also it can be life-saving in patients with systemic allergic reactions to insect venom. Importantly, this is not an either-or treatment. It should be combined with allergen avoidance, pharmacotherapy, and appropriate patient education. Now here we have the typical ARIA summary, that's allergic rhinitis, its impact on asthma guidelines, showing a typical distribution here of mild, moderate, intermittent, and persistent allergic rhinitis. And as you will all be familiar, the key treatments are avoidance where possible, use of antihistamines, and intranasal corticosteroids as first-line treatment in moderate severe disease. And if patients are not responding to this treatment, it's usually because they're not taking it regularly. So we always require a supervised trial of treatment failure before we go on to allergen immunotherapy. Now, what are the indications for patient selection for this expensive and time-consuming form of treatment, which lasts for up to 3 years? Well, firstly, it's indicated in rhinoconjunctivitis with or without asthma. The patient has to have symptoms on exposure to the relevant antigen, whether it be pollen, animal danders, molds, weeds, or house dust mite. They have to have IgE sensitization to the relevant antigen used for immunotherapy. They have to show an inadequate response to treatment, or alternatively have unacceptable drug side effects. If patients respond to topical steroids and antihistamines, there's no place for allergen immunotherapy. Interestingly, we've learned in recent years that polysensitization is not a contraindication. As long as there's a dominant antigen in the history and the patients fail to respond to treatment with pharmacotherapy, this is a good indication for immunotherapy. So what about the contraindications? Very important, severe asthma or uncontrolled asthma is not the right patient for immunotherapy because of the risk of anaphylactic side effects. Whereas, as I'll show you, partly controlled asthma and asthma in relation with allergic rhinitis is an ideal combination. And there are certain contraindications I won't go into in detail, but the presence of autoimmunity, immunodeficiency, malignancy, or a patient who's non-compliant, these are all relative contraindications. And for pregnancy, it's okay to continue immunotherapy in pregnancy, but not to actually start immunotherapy. So now my talk, I want to talk about 4 points. I want to make 4 points, and I hope I can clarify this with data. And I'll go through my slides fairly quickly, but reinforce these important points. Firstly, I want to show you the randomized control evidence that this form of treatment is effective and induces long-term tolerance, both SCIT and SLIT, subcutaneous and sublingual. Secondly, some very exciting real-world evidence published in the Lancet this year for the long-term benefits of allergy immunotherapy. Not just randomized control evidence, but a really high-quality study from Germany involving some 100,000 patients from their national database. And then of particular interest to this audience, rather than talk about pollens, I want to convince you that rhinitis is important in asthma, that this form of treatment using HDM tablets is very effective for perennial rhinitis, and also it's effective for asthma in terms of inhaled steroid reduction and also reducing exacerbations. So long-term benefits. Well, first of all, this is a summary from, you'll see here, DAMI. This was published 4 years ago. This is the European Academy of Allergy and Clinical Immunology evidence that both subcutaneous immunotherapy on the left-hand side and sublingual immunotherapy on the right-hand side are effective in treating allergic rhinoconjunctivitis. And the data shows the mean and confidence intervals for symptoms, medication scores, and the combined scores for SCIT on the left, SLIT on the right. And you'll see anything to the left of the prominent bar on the right-hand side involves efficacy in favor of active compared to placebo. And what you'll see is for both symptoms, requirement for rescue medications during the pollen season, and what is favored by the WHO nowadays, and also the regulatory authorities, the combined scores, which includes medication scores and symptom scores during the season. We're seeing a shift to the left, which is highly statistically significant and clinically meaningful. And this is true both for SCIT and for SLIT. Interestingly, if we just look at the size of these studies, we've got some, we're looking at a huge number of studies that were analyzed here by Aziz Sheikh and his colleagues. And you can see that 160 underwent systematic review. But if you look at the numbers involved, there are hundreds for subcutaneous treatment, where there are thousands for sublingual treatment when we summarize all this data. So the evidence is more powerful for sublingual treatment, whereas the effect sizes are comparable and there is no difference in terms of indirect comparisons. And, you know, as clinicians, we like to see individual examples, don't we? Well, this was the first largest immunotherapy trial performed for subcutaneous treatment. I mentioned this has been around for 100 years. This was a study performed in the United Kingdom, some 400 patients. It was published in 2006. And what you'll see here in our study is that there was a dose response using an alum-based subcutaneous vaccine given weekly for 12 weeks, weekly for 8 weeks in a modified cluster regimen. So updosing over 8 weeks, and then 3 maintenance monthly injections prior to going into the pollen season. And here we have the top dose, the medium dose, and the placebo, involving here 20 microgram, here 2 microgram, and here just the diluent, the vehicle. And you can see during the pollen season in the UK, there was a clear dose response and time course to immunotherapy. And if we look at the magnitude of this, if we look at the entire pollen season, there was a 30% reduction in symptoms and rescue meds. If we look at the peak pollen season, then there was a dramatic reduction in the requirement for medication. And please bear in mind that these results are on top of access to standard state-of-the-art medication with intranasal steroids, antihistamines, and eye drops. So this is on top of usual treatment given to both groups. And what was interesting is when we looked at the sublingual approach, that is a tablet under the tongue daily for 4 months before the season, but then continued continuously for a period of 3 years. What we see here is the weighted combined seasonal symptom medication score. And we can see 33, 41, and 36% reduction in symptoms compared to placebo. And this is on top of access to intranasal steroids and antihistamines during the three years of the trial, with 3 years continuous treatment. This dotted line shows where the treatment was stopped. And then the patients, there were some 600 patients in this trial, some 300 continuing after we confirmed efficacy in year 1. And you can see that this persistent benefit continued for 2 years after discontinuing the treatment. So this is long-term immunological tolerance. This is what makes allergen immunotherapy special compared to pharmacotherapy, the ability to induce long-term tolerance. And at the end of this presentation, there are 4 other studies identical to this. I haven't got time to show you, which show an identical result. So this is really set in stone now. So there we are, persistent benefit for at least 2 years after stopping a 3-year period of treatment. So my first conclusion is that subcutaneous pollen immunotherapy is effective for seasonal rhinoconjunctivitis to tree, grass pollens, and Japanese cedar. Sublingual pollen tablet immunotherapy is effective for seasonal allergic rhinitis. And the treatment should be given for at least 3 years in order to induce long-term tolerance. And this has now been introduced into all national and international guidelines. I'll come to house dust mite later. So the second thing is, well, so much for randomized controlled trials. What about the real world that we live in and practice on a daily basis? Is there any evidence for this treatment being effective when we look across large national databases? Now, the answer is that real world evidence is important because the gold standard is a randomized controlled trial. And that if you don't cut the randomized controlled phase 3 trial, you might as well forget the treatment. But the problem with such trials are that they may not be generalizable to the broader population you see in the clinic. Now, it may have long-term effects, and as you can see, these long-term studies are very difficult to perform in a randomized controlled trial. And also, within the general population, we can look at the impact of this treatment on asthma, and also whether anything else is going on. So it's really important, but there are limitations to randomized controlled trials, mainly, of course, that they're not randomized. And in previous real-world studies, they've not been matched. And that's why this study, published in Lancet European Health very recently, I think is very exciting. This was a retrospective cohort study performed in the entire German health insurance fund database, covering 90% of the German population. And this was performed retrospectively as a cohort study over a period of 10 years. Now, the participants, there were 46,000 of them with allergic rhinitis, with or without bronchial asthma, that were identified in this national database. And they were identified according to whether they took allergic rhinitis medication or asthma medication, at least 2 prescriptions over a period of a couple of years. That's how the diagnosis was made, which was highly sensitive, although not specific. But there were 46,000 patients. Treated subjects. In addition, they had to have the requirement that they had had at least 2 prescriptions of allergen immunotherapy, whether it was the sublingual route or the subcutaneous route, whether it was pollens, animals, grass pollen, house dust mite. They had to have had 2 prescriptions at least for allergen immunotherapy in the index year. That's how they were defined. And then there was a propensity matched control group. And the way this works is complex, but essentially, rather than a group of patients, for example, that were just not on immunotherapy, these were very closely matched, 1 for 1, in terms of age, gender, duration of disease, severity of disease, and all the various demographic procedures. And they were case-to-case matched, 46,000 controls. And 14,000 of this 46,000 also had asthma. Now, the primary endpoint were prescriptions for allergic rhinitis on which the patients were selected. And the secondary outcomes were asthma prescriptions, stepping down treatment, and exacerbations. So the primary objective in this long-term real-world study of some 90,000 patients retrospectively over a period of 10 years was to assess the impact of allergen immunotherapy on rhinitis medication use in patients with allergic rhinitis with or without asthma. And the secondary objective shown here was to look at asthma medication use and worsening of asthma and impact on asthma medications. Now, This is just essentially summarizing what we mean by propensity matching. So 46,000 patients were identified who had the diagnosis of allergic rhinitis with without asthma, and they were matched retrospectively using data over the previous 2 years with a group of patients who also had a diagnosis of allergic rhinitis and asthma and had the identical demographic characteristics, and also were matched on a number of different diagnostic codes. And then the individual patients were matched 1 for 1. And so this is on the basis of the probability that they would actually receive immunotherapy, looking at both retrospectively. And if a patient on active treatment dropped out, then his matched control group also dropped out. So essentially, there was no bias of survivorship, as it were. Essentially, if there are any dropouts, then the partner to the dropout also dropped out, so both groups remained matched. Very important development in the use of real-world evidence. And I can only just show you very briefly the bottom line. There was a marked reduction in allergic rhinitis prescriptions, which was very similar to that observed in the randomized controlled trials. And this was a long-term effect over a period of 9 years. And secondly, when they looked at the asthma outcomes, on the left-hand side, looking at this very large database over a period of 9 years, they were able to show a shift to the right favoring the allergen immunotherapy group in terms of the ability to step down their asthma medication according to GINA guidelines. And on the right-hand side, you can see the odds ratio for developing a severe asthma exacerbation over the period of the study. And you can see here that over the 9 years of the study, and obviously those that were recruited earlier in terms of their time of recruitment, were there were far more of them than those that were recruited later. So the confidence intervals increased. But you can see there was a significant reduction, around a 30% reduction in exacerbations. So in summary, this real-world study extends existing RCT evidence by demonstrating long-term and sustained efficacy. And in patients with concurrent asthma, it was associated with a reduced likelihood of exacerbations. Now, I'd like to now focus on house dust mite, because I'm sure in your countries, and also as in the United Kingdom and other Western countries, house dust mite is a major allergen. I haven't got time to summarize this in detail. I don't need to convince this audience that in many countries, house dust mite is a major cause of both rhinitis and asthma in children and adults, and indeed a predictor of asthma. And what this shows is a 1-year double-blind placebo-controlled trial in some 1,000 patients that were selected carefully for severe allergic rhinitis, sensitivity to house dust mite on the history, and a positive skin test and IgE test. And you can see that over a period of 1 year, there was a 20% reduction in requirements for the total combined rhinoconjunctivitis score over a period of 12 months. And just to show you that this was not a fluke, this was 1,000 patients in this trial. This was another study, interestingly with the same principal investigator, published in the last year. So this is very new data that I'm giving you, with a very similar result, about a 17% reduction compared to placebo in patients with allergic rhinitis due to house dust mite. So what we can conclude from these studies that I've shown you a snapshot of, we can conclude that the house dust mite tablet is effective for perennial allergic rhinitis. You will see that the effect sizes are less than we have previously shown for pollen sublingual tablets, approximately 50%. And I will suggest to you that this is due to the heterogeneity of perennial rhinitis. It's much more difficult to select patients with perennial symptoms compared to those who have seasonal symptoms during the peak pollen season. And I suspect we need to improve by the use of the history and biomarkers our selection of patients. But nonetheless, these effect sizes do fulfill both the WHO and FDA criteria for efficacy in terms of minimal clinical important difference. And finally, I'd like to touch on what is very important for this audience, and that is the role of house dust mite tablet immunotherapy in perennial asthma. And first of all, this study was performed by Mosbeck and colleagues. There were some 600 patients. It was a phase 3 double-blind placebo-controlled trial. It was a dose-response study to the house dust mite tablet that contained approximately 15 microgram of the major allergen, DERPI1, DERPI2. The patients were initially standardized over a period of 4 weeks with an adjustment down to their lowest inhaled corticosteroid treatment compatible with good control. Then they were randomized over a period of a year to a dose response to house dust mite, and they were followed up, as you can see here, with an efficacy assessment over a period of 4 weeks. And the primary outcome in this trial was the dose of inhaled corticosteroids in those patients who received the house dust mite tablet immunotherapy, initially adjusted, and then there was an attempt to reduce it at the end of the trial. And what we can see when we look at all the patients that were on between 100 and 800 microgram budesonide, there was overall a 42% reduction in inhaled corticosteroid dose in the group that had house dust mite immunotherapy. Now, this was not dramatic. It was just under 100 microgram of budesonide. But if we look at the group that were on between 400 and 800 microgram budesonide, which, let's face it, is what we're interested in. Now, this was a post hoc analysis in those patients with more severe disease on the higher dose of inhaled corticosteroids. But here we saw a dramatic 63% reduction, which was around about a 300 microgram decrease, which I think as clinicians, chest physicians, we would regard this as a clinically meaningful result with over a 50% reduction in inhaled corticosteroids. And finally, and I'm sure this study is very familiar to many of you, so I'm just going to touch on it. This was really a landmark trial which has changed the GINA guidelines for asthma and enabled house dust mite tablet immunotherapy to be introduced as an alternative add-on treatment at step 2 to step 4 of the GINA guidelines. Now, in this study, it was over a period of 1 year, and patients' dose of inhaled corticosteroids was initially adjusted to the optimal dose to control their asthma. This was or rather, they were synchronized on inhaled corticosteroids in a standard dose and then assessed. And actually, a lot had only partially controlled asthma, some had fully controlled asthma. But once the baseline was established, they were then treated with a dose response over a period of 12 months with house dust mite immunotherapy. The first 6 months was an add-on phase, and then, in fact, the house dust mite immunotherapy was then continued for 12 months. But during this period, the last 6 months of the trial, the inhaled corticosteroid was stopped. Initially 50% at 3 months, and then 50% at 6 months, and then 100% withdrawn at 9 months, and the patients were followed up for 12 months. So this is the withdrawal phase, and the primary outcome was exacerbations. And essentially, there was a 35% reduction in asthma exacerbations at both doses compared to placebo treatment during inhaled corticosteroid reduction. So at the end of the trial, while the patients were off all inhaled corticosteroids, you can see that there was about a 35% reduction. And this is comparable to that we'd observed, for example, with Xolair anti-IG treatment. The difference is that this is a disease-modifying treatment. As we've shown for pollens, you stop anti-IG, the disease comes back in 4 weeks. With this treatment, you stop the treatment, and although it remains to be shown for house dust mite, but for many different pollen studies now, we can show that there's these long-term benefits. Are there side effects? Yes, of course there are. In the top dose, there was 6% withdrawals due to local itching and swelling under the tongue. This is the dominant side effect of sublingual immunotherapy, but 6% compares very favorably as a withdrawal rate for clinical trials due to side effects. For example, intranasal steroids in rhinitis, there's an 5 to 8% reduction due to nasal bleeding. So this is an acceptable response in terms of treatment-related mild side effects. And there was no anaphylaxis and no use of adrenaline. The treatment was effective and safe. And as a consequence of this, the treatment has been incorporated in the GINA guidelines. This is a summary of the GINA guidelines from last year. And this is one of the concepts that the GINA guidelines use. They offer two approaches to asthma medication. This is the one which you may all be more familiar with. This is the traditional approach of introducing inhaled corticosteroids initially, and then low dose, medium dose, high dose. Whereas the new approach would be to kick off straight away with a PRN LABA ICS combination. But just when we look at this at step 2 and step 3, but also step 4 actually, house dust mite sublingual tablet immunotherapy is offered as an alternative in patients with partially controlled asthma who also have allergic rhinitis due to house dust mite, and this is an add-on treatment to improve asthma control. And I think that's an exciting observation. So in summary, there was a reduced requirement for inhaled steroids, a reduction in asthma exacerbations. The treatment was overall well tolerated, with a draw rate due to side effects depending on the dose between 3 and 6%. And the guidelines now recommend the house dust mite tablets as an add-on option at step 2 to 4 to improve asthma control in patients with rhinitis and asthma. So these are the 4 points I wanted to make. First of all, doubt now, don't more. The evidence for long-term effects of this treatment is unassailable. The real-world evidence I showed you in this new trial published in the Lancet this year, in Lancet European Health, confirms the effects in randomized controlled trials. I've shown you data that house dust mite SLIT is effective in rhinitis, but less so than pollen SLIT, and we need to get better at selecting our patients. And I could give you another talk on biomarkers that might enable us to do this. And finally, the treatment reduces asthma exacerbations and requirement for inhaled corticosteroids and has been introduced into the GINA guidelines. So I'll stop there and thank you for your attention. Thank you very much indeed. I'd be happy to take any questions if there's time.